All right. Well, good afternoon, everyone, and welcome to our webinar on effective approaches to reducing opioid and substance use-related stigma among healthcare providers and first responders. My name is Kieran Karpal. I'm a program manager with the Mental Health and Substance Use team at the Mental Health Commission of Canada, and I will be your host for today's webinar. So before we get started, we would like to acknowledge that the Mental Health Commission of Canada operates primarily on the unceded traditional territory of the Anishinaabe-Algonquin Nation, whose presence here reaches back to time immemorial. The Algonquin people have lived on this land as keepers and defenders of the Ottawa River watershed and its tributaries. We are privileged to benefit from their long history of welcoming many nations to this beautiful territory. We also recognize the traditional lands across what is known as Canada on which our staff and stakeholders reside. As those who are participating today are located across Canada, we invite participants to acknowledge the territory you are joining us from today in the chat box. We also recognize that Indigenous communities carry a disproportionate burden of harms related to substance use and stigma, resulting from structural and systemic issues and policies caused and influenced by colonization. There's a lot of work to be done to address these issues, and we will continue to consider them as we move forward with our work in the area of stigma related to opioid and other substance use. So we are pleased to be offering this webinar in both official languages. Today's webinar will be presented in English and simultaneously translated into French. So to listen in French, click on the interpretation button at the bottom of your screen and select your preferred language. If the French presentation is too small for you to see, you may slide it to one side or the other to increase the size. There will be a Q&A period at the end of the presentation, so please feel free to type in any questions for the presenters in the Q&A box at the bottom of your screen. Finally, considering the topic of the presentation today, I do invite you to take note of the distress line number for your region. We will put some additional information in the chat box. Please do not hesitate to reach out to your local crisis center or distress line for support if you feel that you need it. If you are experiencing any technical difficulties at any point, please let us know in the chat box, and a recording of the webinar will be posted to the MHCC website. If you would like a copy of the slides, please let me know. I will send me an email and they will be provided, and I will be putting my email address in the chat box. So it is my pleasure to introduce to you our speakers for today. We have Dr. Stephanie Knaak, who's a senior research consultant at the Mental Health Commission of Canada and an international leader in stigma research. She holds an assistant adjunct professorship in the Department of Psychiatry at the University of Calgary and is an associate member of the Matheson Center for Mental Health Research and Education. We have Marika Sandrelli, who is a knowledge exchange leader with the Mental Health and Substance Use Services at Fraser Health Authority in BC. We're also joined by Besharah, who is a community harm reduction support navigator at the Leeds, Grenville, and Lanark District Health Unit in Brockville, as well as a peer support worker at the Canadian Addiction Treatment Centres. She's a recent graduate of the Mental Wellness and Addictions Worker Program at St. Lawrence College and has over 25 years of lived experience with opioid use. Lastly, we have Melinda Billett, who is a professor for the Practical Nursing Program at St. Lawrence College of Applied Arts and Technology in Brockville, Ontario. So thank you to all of our speakers for joining us today. So for the agenda, we're going to be starting off with a quick recap of the MHCC and our research program. Then we'll have Stephanie dive into the key messages from our program evaluations and also chat about the Understanding Stigma program. Marika will then discuss the Trauma and Resiliency Informed Practice program, after which Jess and Melinda will talk about their stigma reduction approach with nursing students at St. Lawrence College. Lastly, we'll have a panel Q&A session before wrapping up for today. So the MHCC and our research program. Our work in opioid-related stigma has really involved three main phases. First, we did a qualitative study to find out what opioid-related stigma looks and feels like, how it gets in the way of effective care and services, and to identify promising approaches to reducing this type of stigma. Our second phase involved the creation of the Opening Minds Provider Attitudes Towards Opioid Use Scale. And we also in this phase used it to evaluate promising approaches and interventions to reducing opioid-related stigma. This is really the work that we've been engaged in over the last year and a half. We're now in our third phase, which is sharing what we have learned through our evaluations, as well as building capacity for scale and spread for successful approaches and interventions. Going back to our qualitative study, we did find that stigma shows up in negative attitudes, stereotypes, and judgments about people who use substances. Things like addiction as a choice, negative views about recovery, feelings of ambivalence or reluctance or resistance towards harm reduction, stereotypes and assumptions. We also found that there were a lot of problematic labels and language use, overtly stigmatizing language to more subtle ways that the language we use to label or describe the crisis. Lastly, we also found a lot of exclusionary and discriminatory policies, laws, and inequitable resource allocation, which is basically structural stigma. When looking at promising ways to tackling stigma, there were a number of approaches identified. This included education on addiction treatment and recovery, interventions focused on building client-provider trust, social contact as a key stigma reduction tool, training in trauma-informed practice and care, inward-facing training to build resiliency and mitigating burnout among healthcare providers and first responders, and addressing system gaps and barriers. Each intervention you'll be hearing about today uses at least one of these tactics in their approach to stigma reduction. So now I'm going to go pass it on to Stephanie to discuss the main findings from our program evaluations.
Thank you, Karen, and hello, everybody. It's a pleasure to be with you all today. Before I start, I would just like to share that I am speaking to you today from Golden, British Columbia, which is the traditional, ancestral, and unceded territory of the Knaak peoples. And I come here today with great respect and humility for the land that I am on and for the people who happen to reside here. Thank you. So as Kira mentioned, I'm going to talk a little bit about our evaluation process and some kind of high-level summary of our learnings and findings to date. Just a couple of caveats, though, in terms of qualifying the scope of our work. Karen, you can do the next slide. Thanks. Primarily in searching for promising interventions that we could evaluate, we were mostly interested at that level of kind of public stigma in terms of finding education and training programs that would improve the quality of care and improve the interactions, kind of between providers and clients. So just recognizing that our scope was somewhat limited in that sense, that there's a recognition that structural stigma is a massive, massive issue in substance use and in the overdose crisis. And so just to recognize there that what we're going to talk about today is more at that level of education and training, and we weren't bringing in at this point interventions that, oh, I'm hearing that the sound is not very good. I'm just going to turn up my volume a little bit and see if that makes a difference. Can people hear me any better? Okay, I'm going to carry on and I'll try to, okay, all right, good. Thank you. Okay, I'm going to try to speak a little bit more loudly. So anyway, just a recognition of our scope there. And in terms of the first year of research, we were able to identify 4 different programs to evaluate. And each of the interventions or programs that we identified was identified as a promising approach or program based on those results of the qualitative research that Karen talked about. So each of the different interventions or evaluation or programs incorporated elements that were described as being important for stigma reduction in this context, or the main thrust of the intervention or program was really geared towards addressing one of those key priorities. And it is not to say the 4 evaluations that we did in any way represent a complete, an exhaustion of what's available out there. So there are, other programs that we might not have been aware of, and other programs that, have come online, since we've done these evaluations. So the basic evaluation methodology we used was the same across all 4 of the programs that we identified and partnered with. And it was an outcomes-based evaluation, and our primary outcome measure was that of stigma reduction. And the measure that we used was the one that Karen identified in her introduction, which is the Opening Minds Provider Attitudes Towards Opioid Use Scale. So the OMPATOS for short, we call it, which is a standardized measure that is designed specifically for direct service provider population. So first responders, healthcare providers, social care providers, and it is intended to capture attitudes, behaviors, and caring orientation towards people who use opioids. So each evaluation used that standardized measure as a pre-post assessment tool. So we administered the survey before the intervention, and then we administered it again after the intervention. And then we used user-generated unique ID codes so that we could match individual surveys across the time points. And then our analysis used score changes, mean score changes over the time periods using paired t-tests at the 95% level of confidence. And then we also calculated effect sizes to get a sense of the magnitude of any changes that we saw from any given intervention. So that was the core methodology that we used across all of the different evaluations. But I do also want to point out that each evaluation was also tailored specific to the organization we were working with, to the program, in order to kind of meet the specific needs of what our partner was also interested in learning. So each evaluation might have added additional elements or had additional components in addition to this kind of core stigma reduction measure that we were interested in. So for example, the TRIP program that Marika is going to talk about today, in addition to measuring stigma, because of the type of program it is, we also collected qualitative data and we measured changes in resiliency skills, provider burnout, self-compassion, and compassion satisfaction. And for the St. Lawrence College intervention, which Melinda and Jess are going to speak about today, we used our stigma measure not just for the social contact piece, which was the intervention that we were specifically interested in evaluating, but we also used it to see whether there were any changes in attitudes among the students after going through their standard mental health and addictions curriculum component that is the regular part of their training. And so just so you know, because each evaluation was a standalone project, we produced individual reports on each of those different projects. 2 of them are in report form on the Mental Health Commission website, and 2 were written up as peer-reviewed publications and are either published or in the process of being published open access. So they are all available for anybody who's interested in learning more. And the ones, just so you know, that were published in the peer-reviewed literature are the TRIP program and the St. Lawrence College intervention. And then we also produced a summary report that kind of gave high-level overview of the different findings of our evaluations, and then tried to pull out some general insights and lessons learned from across those different evaluations and interventions. And that's what I'm going to spend a few minutes talking about today. But first of all, maybe just a brief introduction on the 4 programs, so you have a little bit of a basis of what they are. Thanks, Karen. So the first program is called Understanding Stigma. It's a Mental Health Commission of Canada program. It's an online self-directed program that was designed primarily for a general healthcare provider audience. It's free of charge. It's open to basically anybody in the world who wants to take it. And it's available in English and in French. The thing to note about this program is that it is not specific to opioid use, but it is specific to stigma. So it is about the issue of stigma in healthcare contexts, and its primary focus within this context is actually to address stigma towards mental illnesses and substance use more generally in the context of concurrent disorders. The reason we included this evaluation as a part of this larger project is because we were interested in the question of specificity, meaning that if you want to reduce opioid-related stigma, you have to specifically have opioid-related content, right? Or can you use more general content, and are you still going to move the dial? So that was the main reason why we were interested in including this program within our larger evaluation scope. The second program that we evaluated is an intervention at St. Lawrence College with registered practical nursing students or licensed practical nursing students in some provinces, all of whom are in their second year of study. And this intervention is what we might consider a classic social contact intervention, whereby Jess, who has lived experience of an opioid use disorder, comes into the classroom to speak to students about her experiences and her perspectives. And this intervention is used in conjunction with and really as a supplement to the students' regular curriculum when they're learning about mental health and addiction. The third program is Trauma and Resiliency Informed Practice, TRIP for short, which is from Fraser Health Authority in British Columbia. And this is a program that aims to address stigma by, first of all, training providers in trauma-informed practice and care, which was a very kind of direct recommendation that came out of that earlier qualitative research. And B, incorporating this training with an integrated and complementary kind of inward-facing focus on service providers' own experiences of stress and trauma and burnout, which was also identified in that earlier qualitative research. And those two programs you're going to hear a lot more about today. The fourth program that is also included in our summary report, but unfortunately Gord is not here with us today to talk about it, is a program called Stigma Ends With Me, which many of you may already be familiar with. It's a very well attended program, and it has been offered all across the country. And it is another program that showed very positive results and a strong effectiveness in reducing stigma towards both opioid use and also substance use more generally. We actually use two different measures for this evaluation. This program is a program developed by CAPSA, the Community Addictions Peer Support Association, in partnership with CCSA, the Canadian Centre on Substance Use and Addiction. And the particular delivery of the program that we evaluated, and that is included in our report, was an in-person delivered full-day workshop that was co-facilitated by CAPSA and CCSA. And the fifth program I just want to mention, this isn't a part of our discussion today or our summary report, but it is an evaluation. It is another program that we are currently in the process of evaluating. It's called Reducing Stigma and Promoting Recovery for Opioid Use. It's a program that's been developed by CAMH, and it is currently available as a demonstration program. It is available free of charge and open to anybody. It is similar to Understanding Stigma in the sense that it's an online program and it's self-directed. It's different from Understanding Stigma in the sense that it is very much specific to opioid use. So we are very interested in what our evaluation results will show for this program. And we hope to have those results in by the end of the year. So just so you know that that's a part of our larger project as well. Okay, so what did we find from those four programs? Thanks, Karen. Basically, high level, we found that all the programs showed effectiveness at reducing opioid-related stigma. All the programs showed statistically significant reductions in stigma from pre to post program, which means that the change we saw was not due to chance, right? That it was a real change. Now, the one exception, if you look across this chart, that you can see is on the educational curriculum for the nursing students. And I just want to point out that we weren't surprised to see that result. Because we do actually know from the literature and previous research that standard curriculum content in the health sciences often does not reduce stigma. We know from the literature that improving literacy in and of itself or increasing knowledge isn't the same as reducing stigma. So in terms of this result, we didn't include the educational content as a part of our evaluation because it had been identified as a promising approach or a promising practice. We included it because it made the evaluation more robust and stronger because we were actually able to isolate the different components of what students were being exposed to in this context. So I just want to point that out there. And then the other thing that I want to point out on this chart is your column very to the far right, where you see the third column in the orange. And this is actually demonstrating a follow-up result, right? The blue is pre, the green is the post from after the intervention. And in this program, with the TRIP program, we were actually able to collect 3-month follow-up data from the participants who went in this program. And what you can see here is that stigma is actually, our stigma scores are actually reduced even further, just slightly, but they're still going in the right direction. And this, I just want to point out, is actually really, really exciting news from our perspective, because to be honest, it's not what we typically see. Typically, what we see for education and training type interventions is that we see that improvements at a follow-up time period maybe hold, but more often than not, they actually start to dip up again. And you start to see some loss of gains, and you start to see some regression back to baseline. So we are really, really encouraged to see this result, and we're looking forward to kind of learning more about it and really trying to understand some more about implementation factors for this program. I just want to quickly mention too, the other program that we were able to collect follow-up data from is actually the St. Lawrence intervention. The results aren't shown here on the chart simply because our numbers got really small by follow-up, and that makes it hard to have a lot of confidence in what we were seeing. But just so you know that the results we did have, like the data we did collect, did suggest that at follow-up, the gains from the social contact intervention did seem to be holding. So just so you know that. Next slide. All right, just quickly go through some kind of high level, I think, summary points and kind of high level learnings that we've gleaned kind of from doing this work now and these 4 different evaluations and projects. And the first one, I think, is a really strong reinforcement that social contact really is a powerful tool for stigma reduction. And by social contact, I mean using personal story, I mean using personal experience, and beyond that too, not just using that as kind of elements within kind of educational content, but also really having the entire intervention and the thrust of the training really being driven by that lived and living experience perspective and being led by people with lived and living experience. And what I do want to point out and emphasize is that in all of the programs that we identified and evaluated, this was a component in some form or fashion across all of the programs. It was kind of a key element embedded in all of the programs. The second thing I think that we're learning is that opioid-specific content is ideal, it's best, but more general content does also work. So if your goal is to reduce opioid-related stigma specifically, I think the more opioid-specific content you have, the more targeted your intervention is, the better. But what was really, really encouraging for me to see is that more general content that still educates about stigma, that uses personal storytelling, that educates about substance use more generally, and even mental illness, and that also has a positive impact, right? It also moves the dial, and it moves it in a meaningful way. It's smaller, but it still moves the dial. Third, I think we've learned that both in-person and online or virtual can be effective modes of delivery. In the 4 programs we evaluated, 3 of them were delivered in person and 1 was online. And the online program is the Understanding Stigma one. But I also want to point out with respect to the TRIP program that we evaluated, we've actually evaluated that one 3 times now. The first time we evaluated it, it was delivered in person, and those are the results that were written up in the peer-reviewed publication. On the next 2 times we evaluated it, and again, you know, each evaluation we're doing a different group, a different context within Fraser Health. Those interventions were delivered virtually because of COVID, and yet we still saw consistent results across all of the evaluations. We saw no drop in effectiveness as a result of the virtual setting. And participant comments from these from the virtual settings also supported that the virtual model actually works quite well in many respects for a lot of people. Not everybody, but there were a lot of unsolicited comments that did come through saying, you know, we actually quite like the virtual setting. So that is just encouraging again for scale of different programs and making different types of interventions available to different audiences more easily. The fourth point, education in and of itself is not enough for reducing stigma. I think I've spoken to this point already, but I think it was just really reinforced and reiterated in the results we saw from the curricular content with the nursing students. Fifth, both inward-facing and outward-facing approaches are important for stigma reduction. And I think we see this lesson very much from the TRIP program and also from that earlier qualitative research. That stigma really isn't just a problem of attitude. Sometimes we default, you know, when we're talking about that interpersonal level of stigma, sometimes we default to that idea that stigma is really a problem of attitudes. But it's not only that. It's really about building better models of care. And it's really also about attending and attuning to the wellness needs of healthcare providers themselves. And lastly, stigma reduction really should not be thought of as one-off interventions, but implemented as part of a larger strategy. So when we're delivering anti-stigma programs, designing and delivering them, we really need to think about our implementation strategies so that we can aim for some level of sustainability, consistency, reinforcement of messaging, and reinforcement of the skills and the practices that are taught in the training. Okay, so that's a kind of an overview of our evaluation process, some of our high-level results and key findings. And I think I'm supposed to carry on here for a few minutes and just talk specifically about the Understanding Stigma program, which I will do briefly.
Thank you, Stephanie. Yeah, you're up next just to give us a brief introduction of Understanding Stigma and kind of the stigma reduction approach that's used in that program.
Thank you. Okay, for sure. So Understanding Stigma, as I mentioned, we included this program in our larger evaluation strategy because we were interested about the question of specificity. We wanted to know, can you use more general content and still see some positive benefits when it comes to opioid-specific stigma? So that's why we included this program. And just to give you a bit of background about this program, it is the Mental Health Commission of Canada program, but it wasn't actually developed by the Commission. It was initially developed by the Ontario Central LHIN, and it was developed in partnership with the Commission under the umbrella of the Opening Minds mandate back in about 2012, 2013. And then it was evaluated specifically for its effectiveness at reducing mental illness-related stigma in a number of different healthcare settings and with a number of different healthcare provider groups. And it was evaluated multiple times over many years and in many different provinces. It wasn't limited to just Ontario. And it incorporates elements of social contact, personal story and stigma reduction content. And it evaluated well and consistently. And so in 2018, the Commission wanted to move it to an online platform so that it could kind of exist in perpetuity and it could be made more accessible to, more widely. And so when it was moved to an online platform, it also was updated to include some content on trauma-informed care. And it was also, the content was also beefed up specifically on the substance use side and the discussion of concurrent disorders, but there was a lot more content incorporated on substance use. And then it was evaluated again, and it showed that it was still doing what it was meant to do. So then in 2019, 2020, when we were embarking on this initiative to evaluate interventions for reducing stigma towards people who use opioids, we included this program as part of the tool. And And I'll just talk to you a little bit about what we found. You can move the slide forward, Karen. Thank you. So, and we did find, as I showed you in that previous chart, that it did demonstrate effectiveness at reducing opioid-related stigma. But I want to highlight the effect was small. Across the 4 programs that we evaluated, this was the smallest effect size that we found. And I think that's kind of intuitive. That's not surprising. And a Cohen's d of 0.2 for anybody who is statistically inclined or even not, that's kind of the minimum threshold you want to see for something qualifying as a small effect, which is kind of considered a meaningful effect, but you're going to have to look pretty closely to find it, right? To kind of see observable changes in people. So what I take out of this is that there's a lot of advantages to this program because it's readily available online. There are literally no barriers to access. You just have to kind of register and then you can take it. It is available in both official languages, and it's self-directed, and it doesn't actually take that long. It takes maybe 3 to 6 hours, depending on how involved you get in all of the reading and the videos and doing all of the exercises. So I think we recommend it, that it is best used as one component of a larger anti-stigma educational strategy. I think it's a useful tool to have in the toolbox. It's good to know it's there, it's helpful, it does move the dial, but ideally it would be incorporated, it would be used perhaps as a primer or as an introduction, and then it would be supplemented with more specific opioid-specific content. But it does kind of exist as one tool in the toolbox. So I'm going to leave it at that. Just if anybody's interested in understanding stigma too, just so you know, the website for it is just understandingstigma.ca, and that gets you to it. Yes, I'll leave it there. Thank you.
Thank you, Stephanie. So the next speaker that we have is going to be Marika Sandrelli, and she's going to tell us about the Trauma and Resiliency Informed Practice Program and the approach to stigma reduction that's taken in that program. So go ahead, Marika.
Great. Thank you, Karen, and thank you, Stephanie. Hello, everyone. Actually, good afternoon to the folks in the East, and good morning to all of us here in the West. I'm joining you from the unceded traditional and shared territories of the Kwantlen and Keetsi nations, also known by its colonial name as Mission, British Columbia. I want to, next slide, please, or slides at all, please. Oh, next one, Karen. I want to thank Indigenous elders and knowledge keepers, past, present, and emerging, for their incredible contributions of Indigenous ontologies, epistemologies that have really benefited and supported TRIP and a lot of what I'll be sharing today. You'll see here on this slide that Fraser Health provides services to 32 First Nation communities and 5 Métis chartered communities. Next slide. I want to share a little bit about positioning Fraser Health and the context. Here you can see that Fraser Health provides services in the Lower Mainland of British Columbia. It is the most populated health authority in BC, serving over 1.9 million people living in 20 diverse communities, from very large urban centers such as Surrey to cities such as Maple Ridge to rural and remote communities in the Fraser Canyon. 1 in every 3 British Columbians get their health care from Fraser Health. We have 12 acute care hospitals, and over 40,000 staff are employed. And if we include our contracted services, that number increases quite a bit. Next slide. So today I'm going to share a bit about how did TRIP become a promising practice for stigma reduction, and what are we learning, and where do we want to go with this? Next slide. I do want to share a few caveats. I'm joining you here in our collective resolve to end and prevent stigma, and I'm not here as any kind of expert, who has the answers. We're just sharing what we're learning in Fraser Health. And we firmly believe that it really does take a confluence of people and actions and strategies to address stigma. And we're just one tiny piece. Next slide. Also, I'm really keenly aware of the privileged position I have today. My mic is open, I'm at this platform, but behind me, and I'm bringing a large group of people in, and several of you are here joining me today that have been participating in TRIP or contributed to it. The knowledge keepers and Indigenous elders that have been such great teachers and guides, people with living experience have been incredible teachers toward this intervention, families, national supports, and service providers. A huge shout out to the Mental Health Commission. They've invested their time, effort, and expertise, not only in evaluating TRIP, but also supporting its continued development. Next slide. So you've probably, I'm sure most of you are familiar with trauma-informed practice or care, or trauma and violence informed practice. And in fact, a number of you are leading and doing incredible work, wonderful, effective work in trauma-informed care. What I'm sharing with you today is that in Fraser Health, we've taken trauma-informed practice and adapted it for a specific purpose in reducing stigma. And so this is an adaptation. It's not anything that's new or revolutionary. It's for a different use and an adaptation. And what I'd like to share with you is really, how are we defining trauma? So just a little bit of context and definitions here. In Fraser Health, we've used Tara Brock's definition of trauma, and you can see it on the screen. It's trauma is when we've encountered an out of control, frightening experience that disconnects us from our sense of resourcefulness, safety, coping, or love. And, an example could be, somebody going to a clinic, an outpatient clinic, and on their way to the clinic may run into an old friend who reminds them of their partner who they lost to an overdose. And all of a sudden they're flooded with memories. And as they're going up the stairs, they come into the clinic and the waiting room's quite full. And again, feeling even more overwhelmed, possibly impatient, may get loud, may be perceived by people as being disruptive, bad person, all kinds of totalizing statements may come out, when in fact they have a trauma response. They're disconnected from their sense of coping and experiencing the effects of trauma. It can happen for service providers as well. You could be working in a hospital, having a very difficult day, maybe experience some trauma, go to your car at the end of your shift, start your car, go to the end of the parking lot, and all of a sudden you don't know whether you should turn right or left to get home, even though you've done this hundreds of times before. You're disconnected from your sense of resourcefulness. And we do things to get reconnected. Maybe you phone someone, a family member or someone you love, to get reconnected to love or to grounding so you can find your way home. I also want to include, and Stephanie mentioned this, that's on an individual level, but structural stigma and structural interventions are really key and prioritized, and we're learning that more and more. So I'm including the wise words of Sandra Bloom. She talks about, just as the lives of people are organized around repetitive and chronic trauma, so too are organizations. And healthcare and social care is a trauma organized system. Sometimes we use the metaphor of healthcare being a machine, yet we know it's more of a living, complex system. It's made up of thousands of people providing care. And those people are vulnerable. Service providers are vulnerable to the impact of trauma and chronic stress. And also Sandra Bloom uses the metaphor of healthcare as, when an earthquake affects a building, it destabilizes the building. The building still looks intact. The building still can function, but it's been destabilized by chronic stress and trauma. And we provide some short-term solutions to reinforce, but in the long run, we still have not addressed the underlying chronic stressors. So I think it requires both. It kind of looks at the individual, but we also have to look at how can we create more trauma-informed systems of care. Next slide. So I also want to mention when we're speaking about trauma and TRIP, we are looking at a decolonizing approach, and we're also looking through the lens of resiliency. This means that trauma isn't just pathologized or seen as a disorder. It is a natural reaction to the profound injury and wounding that comes from colonization and colonial violence. It's also recognizing that it's not just about building more resilient people. It's about reducing the agents that require us to be resilient. It's about reducing the vulnerabilities that people have to endure every day. And it's about not just focusing or blaming the individual, but looking at larger communities and systems. So that is another lens that we are still developing and learning, but is essential to TRIP. Next slide. So how did trauma-informed practice become TRIP? So in 2013, and I see some of my colleagues here, you may remember, across British Columbia and across Canada, I'm sure, we came up with a trauma-informed practice guide. It was a provincial initiative, and there was 2 goals to trauma-informed practice. It was to reduce the effects of past and current experiences of violence and trauma, and to avoid re-traumatizing individuals. That includes patients, clients, families, natural supports. So we've been, as educators in Fraser Health, we provided education to thousands of staff, first responders, care providers, and an unexpected and quite concerning finding emerged. Participants that were attending the trauma-informed practice workshop were disclosing that they were even feeling more distressed after they attended a workshop. Now, if you're an educator, that's like an educator's nightmare, that you're actually, what you're teaching is actually creating that effect. And so we pulled the bus over, we said, okay, we need to know what's going on here. And we learned that when people had a language and a framework to say, this is happening to me, I'm feeling the effects of trauma as a healthcare provider, but also they're recognizing now that they are traumatizing the people they're serving. And that created such a disorienting dilemma. Their feedback, paralleled what we call a threat response. And the behaviors that they were describing was stigmatizing behavior. Because when we're in a threat response and we get disconnected from our sense of safety, coping, love, resourcefulness, and we're frightened and feel out of control, we can say and do things that are quite harmful and hurtful. And that's the stuff that we were learning. So we started looking at other evidence and content. I think Stephanie was referring to that inward facing. How can we support a workforce that it isn't about necessarily an attitude, it was a response to trauma and distress that we're creating stigmatizing behavior. So we included content around resiliency, content around decolonization, and also a foundation of mindful self-compassion. And then TIP became TRIP. Next slide. So here's the current learning outcomes. I know there's a lot on that slide, and I'm sure you're going to get the slides. Currently, these are outcomes where we are looking at validating the content and looking at expanding the outcomes, not just for individuals, because this is targeting, it's intended for service providers, but also looking at more system and organizational outcomes in the future. Next slide. So far, this is what the intervention looks like. We provide, it's a 2-day workshop. As Stephanie mentioned, we started in person with mental health and substance use service providers. About, I think people that were involved in the evaluation was just under 100 at that time. And so these are staff that are working in safe consumption sites, in opioid agonist therapy, in managed alcohol, in outreach, in bed-based services. Then we moved to virtual due to COVID. And then we moved and did evaluation for people, for nurses and doctors working in emergency, and then expanded to people working in hospitals, primarily with women who are pregnant in the maternity NICU units, and have since now expanded it to multiple sectors of service providers that would come in contact with someone that may be using opioids. We use a very shared common humanity approach. We do that intersectional between inward and outward facing change and transformative learning. And we follow up with a community of practice, a monthly community of practice. I see some of my members here. Participants, it's really to reinforce the learning and to learn from practice. They choose the topics. Some of the topics that we've had in the past year were transforming our understanding of resistance, fostering hope in traumatized settings was another community of practice. Another topic was expanding our own window of tolerance so we can stay connected to our sense of safety, coping, love, resourcefulness. Next slide. So here's some of our learning from TRIP so far in response to stigma. And the theory of change, you can see the diagram, it's pretty basic. It really comes down to the fact that the more we're compassionate with ourselves, the more we can be compassionate with others. And the two converge, and we increase this thing called compassion satisfaction. You've probably heard about compassion fatigue, which some of us find problematic because there's nothing fatiguing about compassion. It's more empathy or work fatigue. But really, it comes down to the premise you can't give what you don't have. And so some of you may be familiar or not with compassion satisfaction. It is something that can be measured, which we did in the pre and post evaluation. It really is that feeling of being connected to your work, feeling competent. It's characterized by positive work relationships, a feeling that your work has meaning and purpose and you're making a difference. So people that come in the helping professions, like we live and breathe that. And when we don't have that, we can experience fatigue and burnout. And there is evidence that higher scores of compassion satisfaction is correlated to reduced burnout. The other thing that we're learning is, I guess, TRIP can't solve all the stigma problems, and it can't fix a traumatized system like healthcare. But what it does, it develops attributes that can work within a traumatized system. And how it can do that is kind of on 3 levels. Within the individual, you can develop kind of a mindful self-compassion practice to be more attuned to how you're showing up in practice, and can look at kind of your own resiliency, get reconnected to your sense of safety. Within teams, it can promote compassion for others, promote positive work relationships. Stigma has a hard time surviving or thriving in those settings. And then within and across systems, and this is the structural work, I think it can foster compassion satisfaction toward a more engaging, safe, and inclusive service culture. And again, where stigma, it's really hard to hide and thrive in those settings. The other thing is I want to say it's highly developmental. It's something that is continuously development. It is, healthcare is a very, what I call a high task, immediate return structure. And TRIP is kind of low task. You have to try different things. and you get longer term results over a period of time. So it does require that investment. And as you notice from my use of language today, it's highly relational. It happens in the affective domain. It happens through emotional connection and that inward, outward facing parallel process. And I want to share with you a quote from a nurse, an ER nurse that participated in the virtual workshop. She said, "I thought this was going to be all touchy and feely and not hard science and not getting to the point of what I really need right now. But now I realized that what I needed to do was to connect with what I'm feeling in this present moment and to attune to others so that I could be receptive and learn from them how I can serve them." And that is hard science. So the last slide, I think we're up. Next slide. So looking forward, we're working now on validating the curriculum with subject matter experts and continuing to decolonize the curriculum and the implementation. We are going to be doing a train the trainer in Fraser Health this year and next year, widely across Canada, and continue to evaluate the program. And most importantly, we're looking at implementation guidelines, how to implement TRIP, including an organizational readiness assessment and how this can be implemented. What are the active ingredients that support the implementation, and some of the results that we were seeing in the follow-up, where we can not only sustain movement towards reducing stigma and all the good variables, but how we can increase those. So thank you very much.
Thank you, Marika. Now we're going to turn it over to Melinda and Jess, who are going to walk us through their approach to stigma reduction with nursing students, specifically at St. Lawrence College, and what they've learned.
Hello, everyone. I am Melinda Billett. I'm a professor at St. Lawrence College, and I want to start by acknowledging how grateful I am to live and to learn and to work on the traditional lands of the Anishinaabe and the Haudenosaunee peoples. And I want to say hi to Jess, who's here as well, and give her an opportunity to say hello before we start talking about our intervention.
Hi, everybody. And again, I would like to thank you, Melinda, for acknowledging that we are on the unceded traditional Algonquin territory of the Anishinaabe people too, and grateful to be on it because we know that we see the Indigenous community overrepresented about 8 times in this crisis that we're facing right now. So it's important to acknowledge what we're doing, acknowledge what we've done, and that there's a way to move forward through it.
Absolutely. So Jess and I have been doing an intervention at a local community college. I think it was 4 years ago that Jess stopped by my office and to chat and catch up. And we started talking about her experience and about what I teach in my classroom, and decided to try having her come to the classroom and chatting about her lived experience. So we can jump over to the next slide, Kieran, and just give you a little overview of the intervention. And I'll start by sharing what we do, and then have Jess include what she talks about and why she shares her story. And then we'll go from there. So this is something that we started. We've done it 3 times now. The first 2 times were in person, and the second time we did it was the one that was evaluated with Stephanie and our colleagues at the Mental Health Commission of Canada. And then the third time with COVID, Jess and I did this virtually. So we've done it that way as well in my class or with my students. So this is an intervention where I teach a component of a theory course to second-year practical nursing students. So these are students who are preparing to finish the 2-year diploma program to register as registered practical nurses in Ontario. And one of the courses they take, their big theory course, includes a number of topics that are covered in terms of looking at epidemiology, pathophysiology, nursing interventions, and pharmacology. And one of the units is mental health and within that unit, I always teach a component around substance use and substance use disorders under that umbrella and that topic in the course. This is not the first time the students talk about substance use in our program. It is covered in our pharmacology course, and that one's more looking at what individuals look like in withdrawal and what they look like when they're using substances. And this course is more about nursing practice and nursing intervention and how to take care of people. So Jess and I talked, and we know each other previously. My role in the community previously was as a primary healthcare nurse practitioner in a community clinic. And so we had that previous relationship that we're clear with our students about when we're sharing the story, that I'm coming as the healthcare provider and Jess is coming as someone with lived experience to share her story. And what we have done is we have Jess come and share her experience of an individual with substance use. And then we talk about what that means for us as healthcare providers and how we think we can have an impact on our profession and most importantly, on the people that we see as we practice nursing. Usually we spend an hour to an hour and a half in the presentation, and Jess shares her story. And the other thing Jess does, which I think the students also really enjoy and get a lot out of, is Jess shares a lot of information about harm reduction and about brings equipment with her, brings supplies, talks about things that people can have to help keep them safe. And I think that's a really great learning opportunity for the students as well. So I'm going to have Jess share about her story and why she shares her story as we continue this discussion.
Okay, so thanks, Melinda. So I have been an opiate user since, so that's given me 25 years. And throughout it, I experienced all sorts of stigma, but what stood out for me and what I would really like to change is, I think, what happened in the healthcare systems. And whenever it was found that I was a substance user, regardless of what I was there for, I was considered a drug seeker and was treated as less than, as if I was taking up other people's time. And it made me feel that way, but it also made me feel that it wasn't okay to go seek healthcare when I needed it. And that's not true, because what happened is I would end up getting really sick and end up in the hospital for days and days and days. Also notice it's really difficult to navigate our healthcare system. It's difficult to navigate for anybody. And if you expect somebody that's living in survival mode, that's barely making it every day to try to make it to an appointment, get there on time, be looking proper, speak proper, it's not going to happen. So we need to lower those barriers for people and make it okay for people to come in whichever way they can. The biggest reason I share my story, and it's ironic because I get full of shame and I get nervous when I talk about it, because I've been told so many times that abstinence is the route, that's when you're going to get better. You'll get better when you'll stop using drugs. And that's just not true. It wasn't until I was introduced to the harm reduction program that I was slowly able to find myself in recovery. So I want to share my experience with that so people stop putting that pressure on people. And also just letting the students know that it doesn't take much to be kind to somebody, that we are people too. We deserve the same health care as everybody else coming in there. And if you're kind and you take care of us the first time we're there, then we're not going to be back 3 weeks later, much sicker, you know, maybe irate, maybe have some unfriendly words to say because of the way we're treated, or maybe not go at all. I've had a friend just this summer who lost a toe and almost lost his entire foot because he refused to go out to the hospital because of the way he was treated. So what I hope to share is that, you know, we are people too. We need to be treated the same way. and we deserve to be treated the same way. And I really hope the students get that. And I hope that they hear the difference between how I've been treated poorly and the times that I've been treated well, and the outcome was phenomenally different. And to take that with them. It doesn't take much to be kind to somebody. It doesn't take much to just give them 1 second. And, you know, hang your biases at the door. If you do have a problem with somebody using substances, you can leave it at work and you can pick it back up when you get home. But don't bring it on the student or on the patient. That's not fair at all. We don't do it with people coming in with a heart attack or with any other illness. And I think the same thing goes to stigma on treatment. If the treatment that we're given fails, we're the people that are blamed, not the treatment. If with any other disease or any other healthcare thing, we'll try something else instead. Not just, you didn't try hard enough, it didn't work, it's your fault. Hopefully that's what the class taken from me.
Absolutely. And we'll chat a little bit at the end about some of the feedback that I've had from my students. And Jess really focuses on, and I try to highlight that and support that in the discussion, is language, choosing words, right? What words we use. And I talk to my students a lot about taking out words that end in an ick sound. So diabetic, schizophrenic, addict, and not labeling people with those words, but actually talking about people who have schizophrenia, talking about people who use substances or people who have substance use disorder or opioid use disorder, and trying to change our language. And that's been a big part of, I think, what Jess and I have been able to bring to our classroom. Kindness, I think Jess said that, and I can't say it any better, that we focus a lot on kindness and how to be kind to people and leave those biases at the door. And choice, we talk about choice and the underlying assumption that people choose to use substances, and that the use of substances is an incredibly complex situation that involves many underlying things, in particular things like childhood trauma. And the need for survival. And so it's been an incredible opportunity to do that with our students. And one thing that Jess and I have talked about and we try to do is around supporting both Jess, I as the professor supporting Jess, but also for the students. And so maybe I'll have Jess speak to, you know, things that she thinks are helpful when she's speaking as the speaker, sharing her lived experience, what helps her as the speaker in that environment to tell her story.
Perfect. So most importantly, I know that Melinda is there and she has my back. If anything's going to go wrong, if anyone's going to say something that's very hurtful or inappropriate, she's going to stop that immediately. So I think it's important for the speaker and the teacher to get together and make sure that that's going to happen, that the speaker is going to be supported throughout it, and to let the students know too that if something's triggering them, that if they need to take a minute, it's okay, that there's somebody there for them to talk to as well. So making it a safe environment for everybody really makes it a better presentation, a lot easier to do, and I think a lot easier for people to hear.
Absolutely. The other thing I do in the classroom is I discuss with the students ahead of time, and I do this for all speakers, but it's really important when someone is coming and sharing their story, that is a vulnerable place to be, that just a reminder to students in the audience about things like the use of a cell phone or a computer and making sure those are put away and they are paying attention and they are engaged. And then this was mentioned earlier too, right? That sometimes hearing things as the audience can be distressing for students or other people in the audience. And so I chat with my students, make myself available to my students, as well as ensure that they know that they have supports within our college where they can access things if they found any of the content distressing or if they need to talk more. They often come and chat with Jess afterwards and ask her questions personally. And so this is something that I think is important for them as well is to have a place and have a professor as well as other supports if the content or what's being discussed is distressing. And the last thing I'll share is around feedback from students. And I share this with Steph and this with Jess, sorry. I was going to say our research study with Stephanie does look at what students said in the evaluation. But what I hear from students above and beyond that and what we see in the classroom is how engaged they are and how much they appreciate Jess coming and sharing her story, talking about what she knows about harm reduction, about supplies that are available, that education piece that's so important. And I will read things from my students that they write months later about a reflection on a clinical experience that they are having where they went, I stopped and I thought about Jess and I thought about how I can act in this situation and how I can be kind to this patient, and I did that. And that is, as an educator, it makes me almost emotional. It's incredible to know that this intervention that we are doing and the time that Jess and I put into this is having an impact on these people and these nurses who are going to be in emergency rooms and are going to be caring for people who are coming in generally, often in the emergency room in particular, in a very distressing situation. And our students are always very thankful to Jess. And I see it months later when they talk about that they hear us, that they hear the message, and that they want to go forward and bring this into their nursing careers with them. And so I'm going to pass it over to Kieran, and I think we're moving on to our question and answer portion.
Thank you, Melinda and Jess. And I always love hearing about both of your approach and love the relationship that you two have with each other. It's lovely to hear, even though I've heard it a number of times. All right, so Melinda's right. We're going to be moving on to the Q&A portion now. We have about 20-ish minutes. So we did have some questions that came in through the registration. We do have a few questions that have come in live as well. So I'm going to try and mix them up with each other. So we'll have a variety of questions. I'm just going to quickly stop sharing my screen so that we can all see each other, or everyone can see our lovely panelists. All right, so the first question, maybe let's go with, since we just heard from Melinda and Jess, one of the questions we got from the registration was, what would you tell a current healthcare student, nursing, physio, health studies, medicine, about the role that they could play? And I'm going to punt this one off to Melinda and Jess.
I'm going to ask Jess. I ask her this question quite often. What do you want nursing students to know? What would you want them to hear?
I want them to hear that we are still people. We are people the same as everybody else. We deserve the exact same care as everybody else. And really, that's it. Just treat us the same as everybody else, and we'll be okay. We'll all get along together. Much better outcome.
And I think I'll add to that, to follow up, that we as nurses, nursing students, as healthcare providers, have the opportunity to impact someone's path. And it might be a little bit on their path because we were kind to them that day, or it might be a lot. And so let's take the opportunity to positively impact our path by being kind and by treating people as people and giving them the care that they need, as Jess says.
Thank you. Oh, Marika?
Yeah, and I think I want to add, I also want to say that also recognize that when you start working, it's going to be hard. You're going to work in a highly distressed environment. You don't have to be perfect. It may be hard some days to be kind, even though you want to be. And you may go home and say, I wish I had said that differently, or I wish I'd done something differently. And don't let that inner critic take over, and recognize we're all human. We're all trying really hard. It doesn't make you a bad person. It's just kind of find some mindful self-compassion, find some way that you can know that you're not alone when that happens, and that we're all working and doing this as best as we can. And it doesn't make you a bad person. It's just that you're working in a highly distressful situation, and it can be a natural response sometimes, and you can tap out. See, that's the other thing, is I think we're all thinking we have to be perfect and we have to know everything and do everything all the time, and that we should be able, we're weak if we can't do something perfectly all the time. When you're feeling that way and attuned and have that kind of self-awareness, tap out, and hopefully we have systems where you're not shamed because you don't think you're good enough. Tap out and let someone else that's in a better place do the work.
Thank you. So the next question that we have is, do you have any tips for tactfully working with program partners or those in the circle of care who may not perceive themselves as stigmatizing? And kind of a related question that we've also gotten are, what are some effective approaches to opening the dialogue with healthcare providers and employees? So I think maybe Marika, I'll give this one to you first, but I'm sure Melinda and Jess might have some comments as well.
Yeah, I kind of caught the last end because I was reading the chat. I can't multitask today. I think I'm learning a lot about the science of receptivity. People can't learn if they're highly distressed. People aren't open. People want to be kind. People want to do things. But when you're dealing with chronic stressors, like to start a dialogue, I would check in to see how receptive, how safe are people feeling? How connected are they feeling with one another? You know, information alone we know is not enough, but you know, people, this kind of highly reflective, transformative process that happens requires safety. So I would really look into, like, how can we create more receptive, safe spaces for people to really look at, you know, some difficult things that they may be doing and saying. And then also, how is the system supporting those conversations? Like, is it safe? So I would look at receptivity is a really big thing right now. We're dealing with a lot of stuff now. There's a lot of stuff going on, and I just think we need to really understand the effects of distress and trauma and receptivity.
Do you want to go ahead, Jess, or do you want me to go?
Well, I'm just quickly, because we're actually doing a lot of training with some of our community partners right now, and it's fabulous. And a lot of it just is lack of education. People think that people are making these choices every day, that they don't want to have a different life, that they're stuck in this lifestyle. Again, abstinent is the only way out. The only way you're going to get better is to go to treatment. And even the fact that we're calling it getting better is, in my opinion, not maybe the right word. It's not fair to say who can take what and when they can take it. As long as everyone is happy and healthy and living a good lifestyle, I think that's okay. And I'll let you pick for Mayor Melinda.
Thanks. One of the things that in my own practice I do, and I'm very intentional with my students about, is the language that we use in our communication, both verbal and written. And this is something when I'm speaking with my colleagues about a patient, a shared patient, when I'm talking to my students, going back to how we talk about people and disease process. And that was from a very early point in my nursing career, where as a student, I worked with a psychiatrist who right from the beginning said, we don't use the word schizophrenic in this unit. We talk about people who have schizophrenia, and removing that label of who people are and not labeling them as their disease process. And so being intentional in how we communicate in writing, when we write consultant notes, when we write notes, progress notes for other people to read, choosing our language, I think has an impact as people are reading that and hearing what we're saying and the words that we're using to impact the words they're using and changing that. So that's one of the things that I have done, and I think is having an impact on my colleagues and on my students.
Yeah, and we can add to that, there's language is so important. It creates, like you said, a culture and changes the culture. And I know in the TRIP workshops, you know, there's some really good, I've learned from our participants, like, you know, we use the word, I heard you, Jesse, say drug seeking. And so we've come up with a list of words that we want to retire. Drug seeking is one of them. We say comfort seeking or seeking relief from pain, attention seeking. We say connection seeking. You know, instead of saying what's wrong, what happened. I think those are really important pieces to this work.
Thank you. So we're going to switch gears a little bit. One of the questions that we got are the results from the qualitative research published? Would love to read further. If so, yes. What we'll do is we will share the links to all of the research reports and everything that is available as part of the email that we'll send out with the recording. But another question that we got is, in terms of social contact, how much time or intensity of the contact is the minimum? And we've gotten a couple of more questions, I think, directed towards Stephanie to elaborate on the social contact piece of programs. So I'm going to punt that one over to you, Stephanie.
Thank you. It's a really interesting question. And I think the short answer is we don't totally know. But I think a lot of it has to do with the quality of the contact more so than the quantity. Like in earlier research we've done, you know, we learned that kind of the more contact you have, the more you're hearing about personal stories, the more that you're learning from people's lived experience, the better. And part of the rationale is that different people's stories are going to connect in different ways with different people. So kind of having a sense of multiple exposure is really valuable, but it's also that it's because fundamentally it is about that personal connection, right? It is about seeing ourselves in others and others seeing themselves in us. And so it really has to do with the quality of the environment in which this dialogue is happening and this conversation is happening, and then the quality of the story, if you will, right? What is actually being shared and how it's being received. So yeah. So in terms of minimum dose, we still don't actually know that.
Thank you, Stephanie. So the next question, and I think maybe I'll send this one off to Marika first, and then invite anyone else to join in. Is the approach in urban settings different from rural settings?
And that's a great question. I think there are core concepts that can be applied across settings. I think there are some adaptations. The one thing, and I know we haven't evaluated this, but what I'm noticing from feedback and from disclosures is that the people that are working in more rural and remote settings, the mindful self-compassion and resiliency components of TRIP really hit home. And that kind of makes sense, is kind of like, because your practice gets magnified and everybody knows you, and if you do something wrong, everyone remembers and everybody knows, it's hard to kind of hide and be anonymous. That, you know, that inner critic or that kind of shame that people carry as service providers, which just exacerbates a threat response, and you engage in more stigmatizing behavior. But anyways, that has more of a potent effect. Like people were saying, oh my God, I never thought that was driving why I'm doing this with patients and clients. And so it seems to be more of a potent. Now that's just from anecdotal. It'd be great to research that a bit more. But yeah, I think that the other thing we're noticing in one of the rural hospitals right now, it's really hard to hide stigmatizing behavior when you start using more of a collective compassionate response. When TRIP becomes the standard, it's harder to hide. So there's kind of some stuff happening there as well.
I would probably say too, like Brockville's a pretty small city. I wouldn't call it a city, but we call ourselves a city. And a lot of people are really sheltered from the substance use world. So I think when they see a substance user or meet a substance user, they expect what they see on TV to happen. You know, they expect everybody to have weapons or to try to hold you up or to put yourself in danger, and that's really not the case, like most of the time. Anyways.
Thank you. All right, so next question. I'm gonna tap on Marika again, actually. Can you please touch on stigma for opiate use as it relates to pregnancy and postpartum supports?
Well, I'm wondering, is Sarah still on? Because we have somebody. I wonder if we can unmute Sarah's mic, because we have somebody from our Mickey program here. Can I tap them?
I'm not sure that we can unmute, but perhaps I can put that question in the chat. Unfortunately, we had to change the format for today's webinar.
Which familiar name for Sarah?
Sarah, it could be, I'm just going to see if I can find, because she's very much involved. We just did the evaluation. So I'm just going to see if Sarah's still here. I'm going through the list. Sorry,
yeah,
you guys.
it looks like she's still here. The name is Sarah Rourke.
Yeah, Sarah, I'm putting you on the spot. Oh, there she is. You can connect with Sarah directly. Yes, Sarah's been an incredible leader, and we implemented TRIP in maternity, the NICU units, for the nurses that are working with women who are pregnant, and she would be the person to connect with.
Great, thank you. So the next question I'm going to give off to Stephanie is, how can you use a structural approach to stigma reduction?
Yeah, really, really important consideration. So maybe I'll just comment specifically for the context of like education and training interventions. When I think about that as kind of a structural intervention, I think about implementation. So it's, so yes, the content of what you're teaching is really, really important. And that's mainly what we've been evaluating through the research that we've been doing. But to me, a structural approach is about how are you implementing it so that it is embedded, so that it is sustained, so that it is, it is reinforced. Like Marika talked about with the TRIP program, the community of practice. That is part of the ongoing kind of reinforcement and building of the developmental skills. And I think those are kind of not missing pieces, but pieces that for sure we need to think about much more strongly, because once you get that piece in place, then you can actually really start to see long-term cultural change.
Thanks, Stephanie. I'm just looking at the time here. We've got about 7 minutes left. So maybe we'll end off with a few questions relating to how people can get involved. So one question was, how and where can a healthcare provider and or patient get involved in the process to be in positions of mental health advocacy, and how can people become better advocates? So this one, perhaps I'll give it to Melinda. But invite others to join in.
Yeah, absolutely. I want to make sure I have the question. Just how can people get involved around advocacy?
Yeah, how and where can a healthcare provider and or a patient get involved in the process to be in positions of mental health advocacy?
Yeah, I'm going to mention this, but I'm going to actually pass this one over to Jess, that if they look around in their communities about what's happening, and I'm seeing it on Facebook with people that I went to university with who are getting involved in things, is finding things in their communities that are happening. So in our community, there are a couple of things that are happening around our municipal drug strategy that Jess can speak to, around a group that is working in trying to reduce stigma right in our community, these grassroots organizations that I think healthcare providers and people with lived experience can come together and work together on. So maybe I'll let Jess actually take that a little bit more from me.
You did a pretty great job. I would just add, continue to network. Every time you talk to somebody who's in another group, get their number, get their name, ask if you guys can connect on some projects. And really, when we go out with our overdose outreach team, a lot of people ask how they can get involved. So there's a lot of people out there in the community that I do know want to get involved. And again, I think it's just networking and talking to people. And as you said, Melinda, there's a lot of grassroots organizations popping up all over different cities, and just checking them out, send them a message, see what you can do to help.
Yeah, just to add to that, I really think you, first and foremost, is learn how to become an ally, learn from people with living experience, and not just from one. Don't try to totalize one experience as everyone's experience, but just really learn how to become an ally. And we need to create systems that employ more peers and that their lived experience drives healthcare. We need patient partners. We need to have safe and meaningful decision-making processes for people with living experience. And that's the first thing we can really work on right now.
Thank you. And maybe I'll ask one last question then, just to end us off. How can we continue to support people in recovery? And maybe I'll give it to Jess first.
I mean, it's really not that hard. Just don't stigmatize us, really. Like, just let us continue to lead our lives. And that's about the best you can do. If you want to give us a pat on the back, if you've noticed a change, or, you know, but just really don't stigmatize us. That's the best I can do.
And can I just add, I think I'm just going to end this because just understand that recovery means different things to every people, and recovery can be a really triggering word too for folks. That I think we have to be open to whatever the meaning, whatever the purpose substances provide in someone's life. We have to understand that, and it's their goals. It's not our goals. It's the person that we're serving. It's really understanding what they want and not necessarily what we want. And so I think that's a really important piece too. and just building on what you were saying, Jess.
And I'll maybe add one last comment too, is that as a healthcare provider, or whoever you are coming alongside people, is see it as that you are coming alongside someone on their path that they're on. And again, it might be for a moment in time, or it might be for a longer amount of time, depending on your role. And appreciate the privilege that we have as healthcare providers to walk along someone's path with them and to have an impact, regardless of the size of that impact. And that we need to be thankful to the people that allow us to join them on their path, and what we learn from them and how we can impact them.
Thank you. All right. So with that, I think we'll end the webinar here. I wanted to say a big thank you to all of our panelists, Melinda, Jess, Stephanie, Marika. Thank you for sharing your wisdom, your knowledge, what you know, and for doing this work, because it's important. And I think the more that we share what we know and what we're doing with others, we can only do better. So thank you again to everyone for being here today. Thank you to all of the attendees. We will be sending out an email with the link to the recording of the webinar after this, after the session ends. It will also include an evaluation survey. So if you have some time, please fill that out so we can know how we can do better. But other than that, thank you, everybody. And I hope you have a great rest of your afternoon. Thanks so much. Bye-bye.